Hello, good afternoon. Hello, this is the most difficult bit. You've just had your lunch and people might feel a bit sleepy or drowsy after lunch, but I can guarantee the next speaker will be providing some really excellent presentation and information. I have the pleasure, my name is Alex Baldacchino. I'm immediate past president for the International Society of Addiction Medicine, and I'll be chairing this plenary lecture, which will be presented by Min Zhao. Now, this is the interesting thing is that I've been communicating with Min for the last 10 years or so, but today, just now, was the first time that I've met her face to face, and that's the way it is, you know, and networks are built in different ways. But without further ado, I'm going to present Min Zhao, who's a consultant psychiatrist, professor, president of the Shanghai Mental Health Center, Shanghai Jiao Tong University School of Medicine, and director of National Center for Mental Disorders. She's a member of several international organizations, the UNODC in particular, but also has been very much involved with the International Society of Addiction and many others. The one thing that always reminds me of Min is that she's ever so graceful around supporting people, young generation of people, but also believing in this international collaboration, which I'm very grateful of. But also, as well, I was looking at all the sort of accolade of Min Zhao, but the last one is that she's a National Distinguished Doctor, Wuzhou Women's Science and Technology Award. Well done, because this is an important statement for young female researchers, psychiatrists in the field of addiction. So without further ado, Min, the floor is yours.
Thank you, Alexander, for your introduction. And first of all, I would like to thank all the organizers give me the great opportunity to share some of our work in China. So dear colleagues, it's our pleasure to meet all of you. Actually, it's my first time to attend the ISAM. I'm a psychiatrist, as Alexander introduced. And I come from Shanghai Mental Health Center. We are the National Center for Mental Disorders. So I do a lot of work on clinical study. So my talk will focus on neuromodulation for addiction, clinical efficacy and application research. So we all agree that addiction is a chronic brain disease. So it's a global public health issue. So there are almost 300 million drug users globally, and the problem remains severe. In China, the form of drug users, including many types, but the number one is stimulants, like methamphetamine and other new type psychiatric substance. Also, in other Asian countries, I don't know, in European countries, the growing concerns is for the adolescent is the gaming disorders or the short video use disorders. The very complex situation for all the substance and the behavioral addiction poses significant harm to the individual and their family and the society. Unfortunately, we don't have much interventions, effective interventions. So that's why we need to develop new interventions. I'm lucky to be one of the member of international advisor member and the field study group members for the ICD-11. So in the ICD-11, substance use and addictive disorder is a big category, I think. For the disorders due to substance use, there are more than 14 types of drugs or substance. In China, stimulants or amphetamine is the #1. So many work I introduced later is focused on the methamphetamine use disorder. Also, a new disease is disorders due to addictive behavior. For example, gaming disorder and gambling disorder. So some of my colleagues will talk in 28 about the gambling disorder and the situations, the research and the intervention in China for other kind of substance use or gambling disorder or behavioral disorders. So I hope if you are interested, you can join us in the symposium for the Chinese symposium. And we all agree that addiction involves multiple brain circuits. So this is a chronic brain disease. It's a relapse brains. So there involves the disturbance or abnormality of brain circuits and functions, including like executive function, pathway or motivation, drive, reward, memory, or learning. And due to the brain impairment, security impairment, there are many key clinical features like craving and loss of control drug use and impulsive drug use. And some have cognitive deficits. Also, the manifest in clinical, they have psychiatric symptoms. So during the ICD-11, there are many mental health disease or disorders is due to the substance use. We call the addiction or substance use disorder is a mimic or for all mental health disorders. So we can see there are many circles. We can see there's so this not good. Yeah, we can see there's many. So this all these circuits or brain damage or impairment is therapeutic targets. So intervention should be targeted all this kind of brain damage. So and clinical pathology features. So which mean like craving or cognitive impairment or psychiatric symptoms. There's a neuromodulation is promised in that they can target the abnormal brain areas or brain circuits. So that's why neuromodulation is very new or very popular in mental health or in other neuropsychiatric treatment. There are many kinds of neuromodulations. For example, RTMS and TES, and also like DBS, both like non-invasive and DBS is a non-invasive one. So in our clinical practice, we explore all three kinds of these neuromodulations in our patients. So I will introduce that later. So for the clinical research, we need to identify the key parameter, which or we call that the main outcomes. So we choose craving, because craving is the key clinical features of addiction, and craving have related to many abnormal neural circuits. For example, the NSA's prefrontal cortex, and there are no effective interventions for craving right now, but there's some medication is designed right now, but no effective medication for like methamphetamine or cocaine or any other new types of drugs. So we think maybe we can use that, we can use modulation. So this is a research frame in our group for the neuromodulation. So we combine the fMRI and the EEG to find the biological mechanism under the methamphetamine craving, to find the target of the neuromodulation. And for EEG, we try to find some biomarkers so it can inform us to develop a biomarker-based closed loop treatment. This is the concept of our research. So this is a research timeline of our group in last 10 years. So from 2014, we start to explore the biomarkers or to explore the brain areas related to craving. Then with this, we use EEG, we use MRI. So in 2007, we do our first pilot clinical study on HTMS to decrease the craving for methamphetamine disorders. It's our first study we published. Then we found that not all people is effective, so we try to increase their efficacy of the RTMS by explore other treatment modules. So right now we are as the time on, we use other kind of neuromodulations, for example, TDCS and DBS. So right now we are doing some like process modulation or closed loop modulation right now. So I will introduce that one by one. So first, we want to find some neuro mechanism under the craving. We use a Dick Stroop task, which we combine the methamphetamine-related cue and the Stroop task. So this Stroop task is to study the cue attention bias of methamphetamine. So I am not explain the detail of the study. So we have like 26 participants of the patients and another 26 for controls. So we found the methamphetamine or MI group exhibited increased P300. But the parameter can get recovered after 3 months. Another finding is that we find that there are like abnormal EEG signals on parietal orbital regions. So this is give us the hint to develop some looped stimulation nature. So this is our first finding, and use fMRI. We try to find the areas or the regions of the brain which is abnormal. So we have we use the cue-induced craving task. So we found that the cue-induced craving showed positive correlations with activation in the suprafrontal grills and pre-serous and other areas, which means it's executive control the pathway or the circuits. Another findings that we found significant positive correlations was observed between PCC and PCQ and RFC functional connectivity, and the craving level is related, which means this areas is related attention network. So it suggests that the craving is related to the decreased function of DRPFC and increased function of VMPFC, which informed us the target areas in future. This is the first clinical preliminary study we're doing for MI craving. But before this study, we found that many study is focused on alcohol or nicotine or other kinds of drugs. One study don't find that it is effective for MI craving, but we in our preliminary study, we use a high frequency, that is 10 hertz of RTMS over the DRPFC for 5 days. We say for 5 days. The sham, there are two groups. Another group is the sham group. So each group will have 20 patients. So this is a published result. We can see the high frequency RTMS is effective to decrease the MI craving compared to the sham group. So this gives us confidence that we need increase the sample size to confirm our results. So we designed a multi-central clinical trial for RTMS for MI craving. So this study including 97 MI use disorders. So divided it into 2 groups in 3 sites across China: Shanghai, Wuhan, and the Yunnan province. So you can see different numbers. So before the intervention is ITBS. It's like high frequency, similar the high frequency intervention over the left air DFBC. But it's only for we intervention for 4 weeks, 5 times per week. So before and after the intervention, we test the craving. Some of them have imaging and EEG. Some of them have the clinical parameter like anxiety, sleep, and quality control, quality of life. So we can see the main result. We found that is the active RTMS. It can decrease the MI craving significantly compared to the sham group. So the MI craving is tested by to ask the patients to see the MI use sceneries, videos, so we can test them. Use the VR assistant system to quantify their craving. So this the main the findings of this study. So maybe many colleagues will, the clinicians will ask, it only decrease the craving. How about it's effective to decrease the relapse? So we designed another study. In China, or in Europe, we have methadone maintenance treatment, but the patients in the methadone clinics, some of them, they also use methamphetamine. So we use this kind of population. We include the patients from the methadone maintenance clinics. So we also we do the randomized control study for 2 groups. One group is the sham one, and for sham RTMS and the active RTMS. So this is before the intervention. We intervention for 1 month and follow up them for another 2 months. So there we have 51 dual diagnosed patients. Means they have opiate but they are in MMT. Also they have methamphetamine users. They are in 2 groups. Outcomes including the urine test, because in China, in the MMT clinics, they come to the clinical. They test. They provide a urine test for each week. So we increased each week. We test for twice to see if they use the methamphetamine. So the result we can see during the follow-up study, the period for the 2 months, the real intervention or the active intervention, their methamphetamine user is lower than the sham group. So in the survival analysis, we see the similar. So in the sham group, they use the sham. After 4 weeks, they all use methamphetamine. But in the active intervention group, the average time is 33 months, 33 weeks. Means so this can decrease the MI users use RTMS. Then we will answer the question why it is effective. So there are 50 participants. They provide the imaging data. So 24 is active RTMS and 25 for another sham group. So I am not exploring the process of the analysis, but the result is that compared to the sham controls, the active RTMS group should increase the connection between the DRPFC to the inferior partial lobes. That means IPL. This circles means it's a control responsible for the cognitive controls. So this is the target areas. We find that the decrease of the craving is positively related to the functional connection between the DRPFC to IPL. We use then we analyze. We also have the MRS to check the glutamine and the GABA level in the DRPFC. So the result shows that RTMS significantly reduced the GABA level in the DRPFC. And the changes of the DRPFC GABA level positively correlated with the working memory in the RTM groups. Now that means maybe it's through to decrease the GABA to increase the working memory, maybe. So as I mentioned earlier, we also use the EEG to check the effect of the RTMS on EEG biomarkers. This we can see some of the results. In the real intervention group, significant beta band power reduced compared to the sham group. And this beta band is related to the quality to the cognitive control. In other studies, it shows that. Another parameter we found is N1 amplified. It means the drug cue and the neutral cue, means reflect the cue reactivity. So this decreased the N1 parameter means also it's decreased and positively related to the craving. So in the EEG level, we can see maybe you can increase the craving, reduce the craving by changing the cue-induced attention. Then we found that we have more than 50 patients have the RTMS. We found that not all the patients have effective. So then we compare what factors affect is related to the outcome of the response or the treatment response. So we divided the patients into three groups by the criteria. After the treatment, the craving is decreased more than 6%. We define that it's effective. So we have three groups. One group is a faster effective one. Another one is a regular reactive group. And now another one group is, the third group is no reactive. So we found the baseline work memory, emotion, impulsivity predict the response. So that leads us to think about how to improve the outcome. Because the RTMS we mentioned is only target one brain region. So only about 60% is effective for the craving. So since the craving is related to many more like security, the circuits or brain regions. So we think about to design a multi intervention, dual target intervention protocol. So this is a protocol we designed. So this one we already introduced high frequency over the DRPFC. So it's only have 60% of efficacy. Another another circuits we call that is limbic arousal lobes. So it's in the MPFC, but it's increased. So we need low frequency intervention to decrease their activity. So we use high frequency to increase the DRPFC and low frequency to decrease their the limbic lobes. So this is our philosophy to optimize the dual targets protocol. So then we design the clinical study. We recruit 4 groups. This is a you can see we have 4 groups. One group is only intervention, the DRPFC. Another group is VMPFC. We can see VMPFC, and the third group is combine the DRPFC and MPFC intervention. So there's each group have 20. We have 18 patients. So the intervention period is 2 weeks. This is the results we can see compared to the sham group. The 3 group is effective to decrease the craving, but the most effective group is the dual modulation group. You can see this. This is the effective rates. It's the same results. We can see the combined intervention is more have more like effective rates. That's we do for the RTMS. Another work we are doing is for the TIS. So TIS we see that closed loop. We see. I can see. Oh, I didn't find that. We designed a closed loop TIS system. Use the Theta brand we mentioned in the before. So we develop this closed loop TIS system and find. Compare the 10 Hertz, 40 Hertz, and 8 Hertz. Then the result shows that the only 40 Hertz modulation is effective to decrease the theta brand of the this is the theta power. So the change in the theta power was correlated with the improvement of the reduction of the SSRT, means the composite, the control. So this is only a preliminary, not published yet. We are prepared that now. So another work is for the behavioral disorders, gaming disorders. We know it's only listed as a disease in ICD-11 in 2017. So I'm happy I'm one of the working with that. So, but we need, in China, the gaming disorder is very important because we see a lot of family, mothers, parents, they take their kids to the clinics to seek treatment. And many parents are very anxious to see many conflict with their kids. So you are you're addicted, but the kids say no. So we don't know the data. So we design a screen tool using the school. So based on the ICD-11 criteria. So this is a reliability and availability study of the gaming disorder screen. It's only 18 items. So if the kids they have a score more than 47, they need to go to further to see the professionals to get more comprehensive assessment to see if they have. So this give them a tool. We use this tool in China. We screen more than 10,000, more than 30,000 kids. We found the prevalence is about for the gaming disorders is about 6%. So it's not as overimpression is very popular, but not really. This only screen, not diagnosed. Is that we all found that the gaming disorder the patient, they have many problems like peer relationship difficulties. They have some difficulty parent-child relationship. They also have many like mood disorder, or they have some low self-esteem and other problems. So under the government of Chinese disease control, we have an expert committee. We develop an expert consensus on the prevention and treatment for the gaming disorder in China. So this published in both English and in Chinese. So we hope we can give some guidelines for the clinicians. For the gaming disorder, one of the areas we are looking is we think is important is interpersonal interactions, because the gaming disorders, they have some difficulty in interpersonal interpersonal relationship is difficult. So they go to they play the games to avoid that. So there's a tools, we call that the fairness, and they can enable us to look at to investigate the mat-brain interaction. So the two kids, they play a game together. We check, we examine their brain activities to see if their interbrain cycling, the IBS is normal or is not. So this is result. We did a study to look at the two gaming disorders. They play games, and we use a firm, the super firm. In the meantime, so we look at if their left DRPFC synchronism is impaired. As we hypothesis, between the gaming disorders or between the normal controls and the gaming disorders, their left DRPFC synchronism is decreased compared to the normal controls. So this gives us a question if we can also use the TIS to modify to modulate their abnormal interbrain synchronism in gaming disorders. So we include 60, you can see 60 gaming disorders, or adolescents, divided into two groups. So we can only report the result. The craving for gaming is decreased after the high frequency TIS. They are training for 2 weeks, and their interbrain synchronism is also increased. So this is our hypothesis. This is another work we do. This is result we can see for the another behavior test for the balloon like risk test. It tests their the same. You can say increase or decrease the norms of the blast of the balloon. Also, the high intensity TIS can decrease their craving, their mood state, and this limitary one day by one is the result. So this some of our work we are doing for both gaming disorder. Okay, okay, we have there are some work we are doing right now. It's ongoing work. We do some cross-frequency TIS for addiction because the literature shows that the cross-frequency couple enables the communication across their cognitive function. So we use that. We use a preliminary study. We show that this high-frequency, cross-frequency TIS can increase their reward learning. And because the TIS, they cannot modulate the specifically for each brain. So right now we are working with a company, some company or some scientific scientists. We are doing the closed loop RTMS for addiction. So these are patents. So we hope I can report or result next time, maybe. Yeah, this is some work we're doing for the DBS, for the treatment for resistant alcohol use disorders. We already recruit for 4 patients right now. Unfortunately, the patients, some they return to use their alcohol, but they report that it's easy for them to control the craving. If they don't want to drink, it's okay, but because the environment, the alcohol is so much easier to get. So some of them return to use, but they feel they don't like the alcohol like before the DBS. Another work we are doing is the TI. So because DBS is elusive for the brain, so we see from other scientists the TI can modulate the deep brain areas. So we are trying to do that. This is some preliminary study we are doing now. So we designed the model for the NIC parameter. So this is right now is still ongoing for not only gaming disorders or for the gambling disorders. Maybe some colleagues will show that later. Okay, it's the summary. Addiction, we all know that it's complex biopsychosocial disorders involve abnormal brain circle function, but we have limited effective treatment currently. So now invasive brain stimulation technology, such as TMS, TDCS, TLUS, have the potential. So there are many Chinese government initiated some requests for application for the modulation, for all kinds of modulations, design new, encourage the new collaboration, new develop for new technology for the disease. So for the night modulation, for the sound modulation. So we hope future, but it's still in the research stage. But you can see only for the RTMS, we develop that into the clinical use is a long way. So we hope we can do more study to find the precise target areas, and the precise intervention should be incorporated with many other factors, or many combine many other neuromodulations together to increase their efficacy. Yeah, I think this is all my talk. I'll thank my colleagues here. Some of them see there, they are doing there, and many grants support from our government. So thank you all for your attention. Thank you.
Thank you. Alejandro Cavaling from Spark Biomedical in the US. Very nice talk. I enjoy it a lot. There's a lot of work. One question. So after you deliver the therapy for the time that you have found that works, how often do the people have to come back to reinforce? Or how long does it last, the effects after you run the full course?
Yeah, very important question. Yeah, many of our studies doing for the inpatients. So after they discharged, we still follow up them, but it's very hard to follow up all the patients. Only one study we induced for the mental clinics. So other studies answer the question how it's effective to decrease the craving, not the relapse, is much more difficulty. Yeah, we think it's very important to follow up them. So, but right now we have a cohort. So all the patients have a cohort. So we will check. But we can see many patients will return to the treatment. Yeah, it's very common, I think. Yeah, but that's why we need to combine the psychosocial intervention together, not only the modulations itself. Thank you.
Thank you. Actually, that was my question around, craving being such a chronic symptom. How would you put the time factor to it all? Thank you. We have another question.
Thank you. Yes, my name is Valgerður. I'm an addiction physician from Iceland. Well, thank you very much. Very fascinating talk. I just wanted to ask you, because you showed us a lot of information on studies you've done on methamphetamine. Do you think, or do you know if for cocaine use disorder would be the same areas that you would stimulate, or would it be a completely different? Is it comparable at all? Methamphetamine stimulation for that, or for cocaine use disorder? And I will also to ask you if you have seen any effect of just a single episode of TMS.
Thank you. Very interesting question. So in China, it's very rare to see the cocaine use patients. So it's, we don't compare that, but we only have the clinical intervention for the methamphetamine. But we do have some intervention for the alcohol use disorders. So maybe in future we can do that for the cocaine maybe. I assume there's a lot of literature working on that. I think it's also effective to the craving, but I don't know for the relapse or the other parameters. Okay, yeah, the single dose, we do the single dose only for the preliminary test, how they change their brain parameters, the EEG, not for craving, but we have a preliminary study, and we have in this one you can see each day we have 5 days. Each day it's effective, I think. This one, yeah, this one. So one day we intervention once. So you can see the it's can induce decrease that. But if we want the effect last, we should intervention longer. I assume that. Maybe we can compare that later. In future, it's a very good question. Yeah, thank you.
Thank you. It's an important question to be followed up by future research. We have lady.
Hello,
there.
I'm Anastasia Demina. I'm an addiction physician from Dijon, France, and we have several protocols using neuromodulatory techniques. And I wanted to come back to the question about the effect during the follow-up, because we finished a study with 6 months follow-up in alcohol use disorder, and it was the biggest trial to the best of my knowledge, because we recruited more than 300 people with alcohol use disorder, and we performed TDCS on right DLPFC, and there was a persistent effect on alcohol intake reduction 6 months after the end of the treatment. So there was a persistent effect, and we obtained a grant from French Ministry of Health to pursue this optimization and potentiation approach by potentiating the TDCS sessions by using cluster TDCS sessions. And I wanted to ask you if are there any longer follow-up trials that are planned in your lab, and how would you deal with this very big limitation in addiction research, which is losses to follow-up, because we can see that very classically in addiction medicine trials there is a lot of attrition. Thank you very much. Thank you for your talk.
Thank you. Your work is very good, and I hope we can have more chance to learn from you. Concerning the follow-up, in China we have, for the MMT, we have a social work system. So all the LP users, or when they enter the system, or social work will follow up them. So we can collaborate with the social work. They take them to the urine test, but they are come from the rehabilitation drug treatment centers, so they went into the system. But for us, like for the medical centers, we are belong the mental health centers. So patients, they are not into the system, so maybe it's hard to follow up them. But we can, same challenge. I think maybe collaborate with the other parties, like social work system, other volunteers, we work together after them to increase the compliance of the follow-up. So, thank you.
Thank you. Min, I have one perhaps technical question. You've measured working memory, considering craving has a lot of subjectivity attached to it. What was the reason why you did not explore autobiographical memory?
Oh, yeah, that's a very good question. So because we are clinicians, so we are designing the study based on the available tools we have. We use the CogState. It's a computerized cognitive function test. So it's only have this kind of work memory. No, that's a very good recommendation. So we can do that in future maybe. Yeah, that's good.
Thank you. Any more questions? Okay, let's share. Oh, I need my glasses, I think. Sorry.
Thank you. I'm a Chinese psychiatrist from Thailand. I would like to ask about the psychosocial intervention during hospitalization. Did they also receive other intervention, and did you assess other functional outcomes like family relationship and all that stuff? Thank you.
Yeah, good question. In different the different study have different outcomes. So for some of I mentioned this one. We have we don't have the family function. So we don't have we only have some mood status or some sleep quality. But for our impression, we think this only related to the brain function. No, so the closely related to their brain function. So why we don't choose the family or social function? That's why. But if we do some study on the relapse, so I think it's very important to include that kind of evaluation. Thank you. Yeah, thank you.
Thank you. Any more? No? Okay. Can we show our appreciation for men? Wonderful.